Welcome.
Hi, Antonio.
Hi, how are you?
Fine, thank you.
Excellent. So, do you want? I'm going to stop my sharing so that you can perhaps try to share your screen and see if everything works fine. Is that all right?
Yeah, yeah.
Okay.
Is this okay?
Yes. Now you just have to remember to put it on presentation mode. So click.
Yeah.
Yes, that's it.
Okay.
Yes, that's perfect. Okay. So that's basically what you have to do afterwards.
Yes.
Excellent. You can leave it with your slide if you want. It's just the
Sorry?
same. You can leave your slide if you want,
Yeah.
and like that we won't need to change anything. Okay.
Let's see just if they go up and down. Okay. All right. All right. All right. Okay.
All right. So
So
it's
is a 6 to 5 to 4.
yes, yes.
So
If you
we should start.
agree, we are going to wait until 4 and
Yeah.
then we'll
Yeah.
start.
Okay.
Okay. Okay.
It was important to know that everything was set up.
Yeah, it is, and
Okay.
so everything is good to go, and we'll talk in a few minutes then.
Yeah. 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 Yeah.
Okay.
Okay.
So, shall we start? Okay.
Okay.
Uh, welcome everybody to this Euro-NMD webinar that is organized in association with the European Reference Network for Neurological Disorders and the European Academy of Neurology. To start with, I'm going to remind you of the rules that we observed during the webinar. So during a webinar, you are not allowed to speak, and but you can pose questions through the Q&A tool, and you can also chat through the appropriate tool with the other participants of the webinar. Uh, as I said, any questions you have, you should write them in the Q&A tool. And at the end of the webinar, I usually unmute everybody and you can voice your question, but in case you're not available, I can also repeat it and Professor Toscano will answer it at the end. And I wish you all a very profitable webinar today. So as I said, Professor Antonio Toscano, a neurologist and a clinician with an interest in neurogenetic diseases and neuromuscular disorders and neurodegenerative disorders as well, is our speaker today. Is particularly interested in myopathies, namely metabolic myopathies and genetic myopathies. He studied also peripheral neuropathies and neurodegenerative diseases. Is the author of over 160 publications in indexed journals and member of the editorial board of neuromuscular disorders and the Journal of Neuromuscular Diseases, besides reviewing for many high impact publications. He also currently is the Dean of the Messina University in Italy and most distinguished clinician. I'm sure all of us have lots to learn today. Thank you, Professor, for accepting our invitation, and the floor is yours.
Thanks very much, Antonio. It's a great pleasure to start these webinars this year. And the topic is quite unusual, I would say, topic because it's the occurrence of both skeletal muscle and peripheral nerve involvement in genetic and acquired disorders. This topic is not always well properly mentioned because it's something that sometimes is neglected, but I think it's important for all interested in neuromuscular disorders to know that some conditions, some clinical condition uh, share either an involvement of skeletal muscle or peripheral nerves. So it's here just to start, just to remind to whom who are not particularly familiar with this topic that the clinical aspects of neuropathy and myopathy are quite different. So, for example, you see in this table that neuropathy are mainly affected because of distal weakness, whereas in myopathy is mainly proximal, and sensory involvement is more proper than neuropathy rather than myopathy. Reflexes are diminished or absent in neuropathy, usually preserved in myopathy. Fasciculations present in neuropathies, not typically in myopathy. Contractures, vice versa, more frequent in myopathies. Atrophy is present in both of them, but with different start. Usually in myopathy is a bit late. And the CK level, it's very different because we have very mild elevation in neuropathies, whereas the CK level is elevated or very much elevated in myopathies. Nerve conduction, of course, slowed in neuropathy and normal in myopathies, whereas the EMG shows large motor unit potentials in neuropathies and small motor unit potentials in myopathy. And what about the neuroimaging? So MRI is very useful in myopathies now. It's very important, especially to establish the degree of scleral adipose substitution or the presence of inflammation. And in peripheral neuropathies, usually the alterations are very mild, so it's not particularly addressing to the diagnosis. And finally, muscle biopsy is neurogenic in neuropathies and myopathic usually in myopathies. So I tried to get a classification of this combined disorder, but there is no classification. So I started to try to include different causes for different kind of myopathies and neuropathies together. And this is the main picture. So we will discuss some of them, not all of them. But for example, we don't discuss about systemic disorders, but we all know that paraneoplastic conditions can provoke either neuropathies or myopathies. But for example, toxic or iatrogenic causes are quite common in the neuromuscular disorders. We'll see this later. Inherited disorders, especially different kind of congenital myopathies or very well-known myopathies as myotonic dystrophy, infectious disorders. And here at the moment, unfortunately, we all know that there is a very important presence of uh, of the SARS-CoV-2. Really, I say again, unfortunately, and this has generated different neuromuscular disorders. There are also inflammatory cases, infiltrative cases, metabolic, as Dr. Atalaya outlined. I'm very interested in this group of disorders, and I'll show you some case about this. Endocrine alterations, and finally, don't forget that sometimes you can also have a double trouble. So two causes in the same patient that can have as a final result a neuromyopathy. So just to remain on the clinical ground, so in skeletal muscle involvement, we can have different forms. We can have acute, subacute myopathy, and they are characterized by hyperschemia, muscle weakness, myalgia. Less frequently rhabdomyolysis, but when rhabdomyolysis is present is a dangerous situation because it can cause a renal insufficiency that can lead to an exitus. But this is a very rare circumstance, luckily. On the other end, the peripheral nerve involvement, we have, of course, an involvement either motor or sensory, and we have also different form of neuropathies. We have a distal axonopathy, we have a mononeuropathy, we have a multifocal neuropathy or demyelinating neuropathy. And all these forms are characterized by hyporeflexia, paresthesia, and muscle weakness and wasting. Because of this great variability of causes, of course, diagnostic workup is very difficult. And in this list, you can see that there are several items we have to take into account, like patient history and family history, especially for the genetic disorders. Of course, the clinical evaluation, the results from laboratory examinations, the neurophysiological studies that are still very fundamental, and also we can also use muscle or nerve biopsy in specific situations, especially for nerve. And we have also to consider the iatrogenic weight of toxins or drug, and we have to consider when these toxins or drugs disappear, and they may have a different situation before and after use of toxins or drug. And finally, again, especially in genetic disorders, molecular genetic studies. So just to start with toxic iatrogenic agents, one cause which is today a little neglected is the alcoholic patients. So we can have an acute myopathy, which is very, very rare, but there is still, and it's characterized by myalgia, muscle weakness, hypercemia, and renal insufficiency can occur, but is more often present the neuromyopathy in subject alcoholics. So about 50–70% of them have a neuromyopathy. And this is characterized by a progressive muscle weakness, atrophy, and a sensory motor, even autonomic neuropathy. You can see here on the right-hand side, this is a sort of specimen from a nerve biopsy. You can see that there is a very great lack of nerve fibers. And here, another group of agents that can cause neuromyopathy are the lipid-lowering agents. Particularly, you all know the statins, which are very important drugs for prevention and treatment of hypercholesterolemia and coronary artery disease. And there is a large variety of situations from 0.1 to 10% of cases that can have rhabdomyolysis, myopathy, or neuropathy. We don't know exactly still all the components of the pathophysiology of the statin myopathy, but we know that there are some patients that are particularly prone to the rhabdomyolysis when they have a genetic variant of the SLCO1B1 gene that affects the uptake, the hepatic uptake of statin, and might increase the possibility to have an elevation of CK. Another situation is when statins may uncover a previous muscle disorder that was not discovered so till then. And when the patient, after statin withdrawal, still have muscle disorders, muscle signs and symptoms, it is important to try to be persistent and might be to give him a muscle biopsy to see if there is another myopathic cause to determine muscle weakness and CK elevation. Another group of agents like anti-HIV agents, and this group is still able to produce myopathy or neuropathy. You can see here that, for example, when this nucleoside analog reverse transcriptase inhibitors, you know the names as zidovudine, clevodine, stavudine, may provoke a neuropathy, which is an axonal sensory motor neuropathy, because there is a direct toxic damage of peripheral nerves. On the other side, if you look at the involvement of skeletal muscle, as usual, you can have hypercemia, you can have muscle weakness, you can have myalgia, but those situations are usually due to a mitochondrial dysfunction. And if you perform a muscle biopsy, you definitely will see in several instances ruggy red fibers and COX negative fibers that are sort of biomarkers of these mitochondrial alterations due especially to mitochondrial DNA depletion. And here, a group of different agents. So I would like to start with to show you a case of a female, 20 years old, and that has been treated with an experimental trial with colchicine because she was affected by cystic fibrosis. After 3 months of treatment, she started to complain myalgia, difficulty of in climbing stairs and raising from a chair, and paresthesia at limb extremities. So at neurological examination, there was definitely a proximal lower limb muscle weakness. There was an elevated CK, and the neurophysiological examination showed either a myopathic pattern, but also there was a reduced sensory conduction. Explaining the mixed symptomatology. And here, the muscle biopsy, you can see that either at hematoxylin eosin or at trichromic stain, there were evident vacuoles. And if you look at the acid phosphatase, these vacuoles were hyperreactive, as happened in lysosomal dysfunctions. Colchicine was stopped, and there was a gradual improvement with only of muscle symptoms, but only paresthesia were left. Normal CK and the neurophysiological examination normal after 3 months, and definitely the diagnosis was the colchicine-related myopathy. This is just to give you a sort of a model, because rheumatologic agents, chloroquine, used for several kind of disorders like pemphigus rheumatoid arthritis, might provoke myopathy. Antimicrotubular agents as colchicine may provoke myopathy and sensory neuropathy. Cardiac agents as amiodarone, very well used for arrhythmia, may cause peripheral neuropathy and proximal myopathy. So all these agents have a similar pathophysiology, because they are all interfering with the lysosomal functions, causing a sort of alteration of the autophagic processes at muscle myofibers level. So now a different group of agents. This is a quite new group, because you know that immune checkpoint inhibitors are especially used for subjects, unlucky subjects with advanced malignancies. You see metastatic melanoma and Hodgkin's lymphoma and so on. And these agents can provoke an upregulation of the immune response, and we'll see in a scheme. And here there is a list of this kind of disorders as ipilimumab, pembrolizumab, and others, novolumab, and all these agents may provoke or an aggravation of a pre-existing disorder, like, for example, myasthenia gravis, or they can cause immune-mediated necrotizing or inflammatory myopathies and inflammatory polyneuropathies. So this is, unfortunately, with the use of this kind of agents, is not so rare. And here, the possible immunopathological mechanisms, you can see that these checkpoint inhibitors can remove the costimulatory molecule control, and this can provoke different autoimmune complications that can complicate pre-existing autoimmune disorders, or they can develop autoimmune disorders. And this kind of disorders are quite difficult. You can see in the center of the slide the main cases: myopathy, necrotizing myopathy, very hard to restore it, polymyositis, dermatomyositis, myasthenia gravis, neuropathies, especially these immune disorders or vasculitic neuropathies. And this is a very challenging situation, because it's not so easy to treat successfully all these cases. And just to finish this group of agents, critical illness inducing agents. You know that critical illness is something that is a very it's a subtle disorder. So it's sometimes difficult to recognize it. Here, a case of a 26 years old man admitted to ICU for a traumatic brain injury, and he was treated for a long time with methylprednisolone and curariform agents, and then assisted because of respiratory insufficiency. In few days, when after his admission, developed an acute tetraparesis, no pyramidal signs, so this means that was not related to directly to the trauma, but of course it was related to the use of this kind of drugs. Tetraparesis present, elevated CK, myopathic pattern, but also a reduced amplitude of MAP and SAP at 4 limbs. So this was the picture, the morphological picture. You can see that a lot of fibers had vacuoles, but also there was an intermyofibrillar disorganization in the skeletal muscle fibers. We decided to withdraw the methylprednisolone and the curariform agents, and 5 days later, the patient went off the ventilator, was admitted to the rehabilitation unit, and after 6 months, he still was affected on discharge with the proximal weakness, but was able to walk. And this was a classical case of critical illness neuromyopathy. And you know that there are several inducing agents for this critical illness, especially non-depolarizing neuromuscular blocking agents or very high dosage of steroids, but also in this situation in ICU, not difficult to get, unfortunately, not difficult to get sepsis, and also the immobility is something that can aggravate the situation. So if you look at the slide on the right-hand side, you see that there is a lack of intermyofibrillar components in the middle of the fiber, and this was evidence of thick filament loss that was confirmed by electron microscopy. There was a type 2 fiber atrophy, and this was the basis for the diagnosis of critical illness. I would like to outline that there is something that from the neurophysiological point of view that is important to know. Sometimes the loss of the membrane excitability may mimic an axonal neuropathy. So in this case, it's very important to have an expert neurophysiologist that can follow the case. And of course, to try to recover, it's important the physical rehabilitation. So the second group is mainly based on congenital myopathies. This is one of them, and this was a progeria case. And progeria is based on lamin AC mutation, but also there are also the Danigan familial lipodystrophy is based on lamin AC deficiency, and muscle and nerve can be involved, as well as other cases where several other congenital disorders, myopathic disorders as IBM or GNE or myofibrillar myopathy can also be accompanied by neuropathies. And it is known that also myotonic dystrophy, which is probably the most frequent muscular disorder, can have of course, important muscle weakness and wasting. The effect on peripheral nerve is less known, but there is quite a wide literature about the presence of neuropathy in myotonic dystrophy, and about from 25 to 45% of the M1 patient had numbness, paresthesia, or dysesthesia, and once you can use the neurophysiologic examination, you can find you can have a confirmation of this peripheral nerve involvement. Also, in neural nerve biopsy, when they were done, there was a reduction of myelinated fibers. This is an example of the literature. Is the group from the Netherlands, and they studied 93 patients, and 17% of them had mild sensory signs, and the presence of neuropathy was also evidenced by distal muscular weakness and wasting. But it is important to outline that this neuropathy was not linked to diabetes, which is very often present in myotonic dystrophy. So another big chapter today is the infection due to SARS-CoV-2. And this is a very new literature, and the main the main topic are Guillain-Barré syndrome, myalgia, fatigue, and hypercemia, and again, ICU acquired weakness. Guillain-Barré can occur after 5-10 days following the respiratory symptoms. We can have a variability in the clinical aspects, mild courses of even severe tetraparesis with cranial nerve involvement is usually is a neurophysiological demyelinating pattern, and intravenous immunoglobulins as well as plasma exchange are quite similar in effects, and they are really effective, but they have to be started timely. Also, some Miller-Fisher syndrome have been described, and talking about the specific myopathic side, it's quite common that you can get, especially in the first 1 or 2 days, an increase of CK. Over 30% of patients show this, but in a limited number, you can also have an important elevation, like a rhabdomyolysis. And there is just one case described with myositis associated with the SARS-CoV-2 infection. And in Italy recently, there was the occurrence of some cases of myasthenia gravis started after the onset of SARS-CoV-2 infection. And as I said before, also in the ICU, some acquired weakness that were due either to CIP, in other words, critical illness polyneuropathy, or to CIM, critical illness myopathy. Both can be present in the same subject. And of course, they are characterized by diffuse muscle weakness and atrophy, and there is also an involvement of respiratory muscle and even a sensory deficiency. So these cases, of course, may worsen during the intensive care treatment, and there are several triggers as sepsis, multi-organ failure, hyperglycemia, and so on. Another group, infiltrative amyloidosis. So amyloidosis at the moment is very well considered, because you know that there are several new drugs that can interfere with the expression of peripheral nerve involvement in amyloidosis when this is specifically related to transthyretin alterations, but we can also have a different picture. So amyloidosis can produce a small fiber neuropathy, a progressive polyneuropathy, can produce an axial myopathy, can produce a neuromyopathy. And this is a very interesting paper where in this picture there is a summary of this situation. So amyloidosis, amyloid myopathy is due to AL amyloidosis. We have a large number of patients with transthyretin amyloidosis, but we also can get some amyloid myopathy. Here, a case we had a few years ago, a man of 57 years, acute onset of the disease, characterized by diffuse myalgia, dark urine, proximal muscle weakness, and difficulty in walking. No fever, no drugs that can cause this disorder. Very high level of CK, and you also see the small lambda IgGM component. The myopathic presence, neurophysiological examination myopathic, and neurography normal. This patient was initially diagnosed as probable polymyositis in subject with monoclonal gammopathy. Started to be treated with deflazacort, but no benefit. About 10 years later, he came to our hospital, and the neurological examination was really bad. Important proximal muscle weakness with hypertrophy, especially of periscapular and quadriceps muscles, myogenic electromyography, neurography normal. But when we studied the neuroimaging, there was a diffuse atrophy of thigh muscles, especially in the posterior area. And the lab test confirmed the immunological alteration. And this is the classical muscle biopsy in this case. And you can see when you see the slides at Congo red, there is an important reaction. And because there were several MAC deposits found, especially in the vessel walls, but also in the muscle fiber surface. So this result was typical of an amyloid myopathy, and the patient was immediately treated with melphalan, and he also with betamethasone. He had an important recovery. Later on, 3 months later, although the neuromuscular examination was not particularly different, but he was better. He felt better, and the level was still, the CK was still maintained about 1,000. And the comment is that he had a very late diagnosis, I would say. So a lot of muscles were already compromised, although there was the possibility to stop this situation using the appropriate treatment. So when we talk about metabolic disorders, there is a large number of possible causes. So I will try to limit this group of disorders because of the time, but I would say that muscle glycogenosis, especially branch and debranched deficiency, may involve muscle, but also peripheral nerve. Danon disease, which is a lysosomal disorder, I would outline, is mainly affecting the skeletal muscle, but if you look at the literature data, about 10% of patients with Danon disease have also a peripheral nerve involvement. It is interesting also that in lipid storage defects, they are very, very different. There are different defects, like for example, the multiple acyl-CoA dehydrogenase deficiency. You know that this is a very important cause of muscle deficiency, but luckily it is possible to reverse this situation using riboflavin, especially, and might be also carnitine or coenzyme Q10 in specific cases. When you have to deal with this kind of disorder, usually is a myopathy, but also some peripheral neuropathy can be seen in the same patient. But definitely the majority of cases, including either muscle disorder and peripheral nerve disorder, are under the mitochondrial dysfunction uh, dominion. And we'll see in some cases. So I would like to celebrate this part of my talk, showing you the photo of a very important person in the field, who is Billy Di Mauro, who was one of the really real father of the mitochondrial studies. And we had the chance to give him a PhD honorary in the University of Messina a few years ago. And he is very well known to you all, I suppose. And mitochondrial disorders are, of course, heterogeneous group of inherited disorders and are multisystemic disorders. And the dysfunction of the mitochondrial system is due to a damaged oxidative phosphorylation system. So starting from this, we also know that in mitochondrial myopathies or in cephalomyopathies or mitochondrial disorders, if you want, there is involvement either of the mitochondrial DNA or the nuclear DNA. Sometimes they are both implicated in the different mitochondrial syndrome. Here you can see that there are several organ tissues involved, but we can also find involvement of skeletal muscle and peripheral nerve in mitochondrial disorders. Here, the genetic classification, you know that there are mtDNA alteration and the nuclear DNA genes, but also there are defects of the mtDNA maintenance, defect of mitochondrial motility, fission and fusion, and this is important, and defect of the lipid milieu. There are several sites that can be affected by the and provoke mitochondrial neuropathies, and this is a very recent paper and by the group of Mark Tarnopolsky from Canada. And you can see that the peripheral neuropathy is present in several mitochondrial syndromes like Kern-Sayre, MELAS syndrome, MERF syndrome, but not only. This is a real detail of different kind of neuropathies that can be involved in mitochondrial disorders, sometimes as a predominant feature, and in other situations are very important clinical aspects, but in other are just a minor feature. We have a different kind of neuropathies, axonal sensory motor, the myelinating, especially in Mengi, we'll see in a minute, or in MERF, but also mainly sensitive neuropathy as in NARP. And here, this is just a table from a very historical and well-known paper done by Billy Di Mauro's group, and you can see if you look at the presence of peripheral neuropathy is present in Kern-Sayre syndrome, is present in MERF, is present in MELAS, is present in NARP. Whereas, of course, muscle involvement, especially muscle weakness or ophthalmoplegia or ptosis are very often present in mitochondrial disorders, sometimes are the reference signs for the clinicians. And here, just an example, a woman 30 years old, she started to complain paresthesia and distal weakness at upper limb. This is the problem. 2 years later, she complained of easy fatigability and paresthesia at lower limbs. When examined, she had a bilateral foot drop, pes cavus, severe distal muscle wasting and at upper limbs, whereas was moderate at lower limb. And normal deep tendon reflexes, but distal sensory loss at 4 limbs. So she was examined, and from the neurophysiological point of view, there was a neurogenic pattern with the reduction of sensory conduction velocities. And whereas the evoked motor potentials were all normal, so this excluded a number of other possible, and because the clinical aspect was the resembling a Charcot-Marie-Tooth, she was investigated from the genetic point of view, and really she had a mitofusin deficiency. So this is one of the cases that is involved in the motility fission fusion. And here, the main clinical picture of the Menge syndrome I mentioned earlier. This is a very devastating mitochondrial disorder. Commonly, you can see in the patient the of external ophthalmoplegia, proximal muscle weakness, and also you can find symptoms of neuropathy. But what is very important is the severe gastrointestinal involvement that provoke cachexia, and these patients are really severely affected. And also there is an involvement of brain by the presence of the leukoencephalopathy, which is very recurrent, high lactic acidosis. And when you perform a muscle biopsy, you can see Raggerate fibers, Cox negative fibers. And generally, this is uh, um, um, mitochondrial disorders due to depletion or multiple deletions. Why is important to mention this among the others? Because there are several attempts now, therapeutic attempts that seems to be promising, although still not available or already available. And this is another group of mitochondrial disorders due to POLG deficiency that can cause a mitochondrial DNA depletion or multiple deletions. And some subtypes of mitochondrial disorders can include, as the one included in this picture, and they can involve peripheral neuropathy. And this is particularly evident in this work done by a group of uh, American and Japanese and Chinese colleagues. They studied the manifestation of patients with POLG mutations at different ages. You can see that the majority, these columns are particularly devoted to the presence of peripheral neuropathy. And what is the biomarker, the hallmark of this disorder? So again, in the muscle biopsy, the Raggerate fibers or the Cox negative fibers, alteration of the cristae mitochondria, and from the molecular point of view, the presence of multiple DNA, multiple with different deletions, definitely indicating the possibility that the POLG is a mutation causing the multisystem disorder. So also there is another group of patients that can be affected either for skeletal muscle or peripheral neuropathy because of endocrine causes. And finally, I would like to remind you that sometimes we recognize one disorder, but in the presence of other signs or symptoms, we are still skeptical about thinking of two disorders. This is a group of different papers where, for example, a mitochondrial trifunctional protein, which is a lipid storage disorder, was together with the Charcot-Marie-Tooth, or again, the same trifunctional protein presented with the rhabdomyolysis, or trifunctional protein present with peripheral neuropathy too. So in conclusion, I hope I have been clear because this is a very difficult field. And I would like to conclude saying that neuropathy and myopathy can be together, and this is not so rare. Although sometimes there is the prevalence of one of the two form, and we need really to, knowing this with this background, we really need to carefully investigate these disorders, not to neglect one of the two possibility. And in conclusion, it's very important, as usual, to think about different disorders, because as you have seen, several of these disorders can be treated, but it's important to make an early diagnosis to treat them properly and in the with the right time. So this is our arbor in Messina, and I would like to thank you all for your presence to this webinar, and I'll be happy to get your comments, curiosities, or questions. Thanks very much.
Thank you very much. I think that was a very enthusiastic and interesting communication about the complex subject. For the moment, we have an open question. Eva, if you want to speak up your question, you can unmute yourself and talk live, otherwise I'll read it. Okay.
Hello,
so,
yes.
okay, go ahead.
Yeah, so we were talking something about the COVID and neurological consequences, and we had one case in Slovenia with facial palsy, so a palsy of nerve facialis. After the COVID infection, and I was wondering if you have any experiences with that.
Yeah. I can tell you that we also had one case with a similar situation, and this was after COVID infection, and he recovered from this point of view. Luckily, it was a luckily benign case, and we had this experience. Definitely, I didn't know that there were others around. It's very important to know.
So in the chat, there are some thank yous for the presentation as well. But I know that I've read that some of the attendants are very remarkable and distinguished guests, but I'm not sure. I have a question. So Alonso Jimenez Alicia. Alicia, do you want to unmute yourself and put your question live, please? She can't, so I'm going to read the question.
Okay.
So she has a question regarding the neuromyopathy secondary to HIV treatment.
Yes.
Do you know, or have you ever seen myotonic discharges in relation to this kind of neuromyopathy?
Honestly, I can tell you no. I didn't have this experience, and honestly, I never had this kind of this myotonic discharges in this kind of patient. But ideally, I would say that it is possible. Why not?
Okay.
Myotonic discharges are present in several neuromuscular muscular disorders. It is well known that, for example, Pompe disease at axial muscles level, as the majority of patients have, but might be this is a neglected area. But yes, it is possible.
Okay. So Mariam Kekedadze has the hand raised. Do you want to unmute yourself and speak up?
Yes, thank you for presentation. My question is, during COVID-associated neuropathy, is there any specific?
Sorry?
Sorry, Mariam, unmute yourself. Something has happened.
I was muted.
Sorry.
Okay. So my question is, during COVID-associated neuropathy, is there any specific treatment that you use in patients? And then I have another question from my clinical practice. I have a patient with myasthenia with anti-MuSK antibodies, and she has developed left leg weakness, and on ENG there is neurogenic pattern. So I was thinking, is there any association with myasthenia and probable ILS, or do you have any comments on this fact as well?
I mean, I have shown that the possibility that there are two or two different neuromuscular disorders in the same subject is possible. So I wouldn't be surprised of this. Specific treatment, I would say no, because if you consider IVIG or plasma exchange specific, yes, but because they are quite common, I wouldn't say that they are specific.
Thank you.
Okay, so I think we've gone through all the questions from the audience. I would like to ask you a question, if possible, and that has to do with the toxic effect of the different drugs that you've mentioned.
Yeah.
And nowadays, what I'm concerned about is the risk of potentiation between some of those drugs when they are used together. And so in the past, at least, it was not uncommon for people to take clofibrates with statins.
Yes.
So do you think, in your experience, that does trigger more severe cases? What difference?
Thanks. This is quite a recurrent interrogative, I would say. Although I have the feeling that now the use of combined fibrates and statins is very, very reduced. So there was a potentiation of the damage using both of them, but I would like to reverse the question, say that one of the main problems today is the use of sort of unspecific drugs that are considered from the patient not really involving the statin potential damage. So, for example, red rice, there are patients that use red rice rather than statins, and they are convinced that they are completely normal. But red rice is a sort of statin. It's a natural statin, but it's the same area that can damage. So nowadays I think that use of fibrates, especially with in conjunction with statins, is quite rare. I mean, at least in our country. What is more recurrent is the use of integrators, so-called integrators, that sometimes are dangerous as well as statins. The patient has need to be made aware of this, because sometimes, especially, I don't want to criticize, but some GPs use this kind of drugs, saying, well, this is no problem with this, it's a different one, it's the same one.
Mm-hmm. And so perhaps I don't see no more questions, but just to finish, just another one, if you don't mind. And okay, so in terms of management and prognosis, the simultaneous neuromyopathic triggering or disease, what extra management or what extra precautions would you recommend in those cases?
Well, we are strictly involved in making aware physicians about this problem. So this is probably the first thing to do. So to try to increase the awareness of physicians about the possibility to have double trouble, because the attitude of all of us usually is to try to consider just one disease and to eliminate the other things annoying us because are not really fitting with the main diagnosis we have in mind. So this is wrong.
Mm-hmm.
But apart from this philosophical consideration, I would say that today I still think that the neurophysiological examination is very important to try to make us aware about the double trouble in terms of skeletal muscle and peripheral nerve involvement. So this is very important. And this is in my opinion, an obliged passage for this kind of patients. I can tell you that in the management of these patients, something that is really useful, as you perfectly know, is the use of skeletal muscle MRI. Because in sometimes where it's not possible to perform a muscle biopsy, for example, because not all the centers are completely equipped for this, muscle MRI can give you some specific informations, especially, for example, for inflammatory disorders that are very useful. And you can manage the patient with drug without the muscle biopsy. So this is another. Then the situation is more and more difficult, because if you are in presence of genetic disorders, that one is a very difficult situation, because you know that till now we don't have perfect perfect result from NGS or exoma or other techniques, because still there are a lot of patients that remain not diagnosed.
Yeah. Well, I think I wish to start by thanking you very much, Professor Toscano, for your participation. This webinar was highly interesting, and I'm glad to say that it will be available through the Euro-NMD website afterwards. So even after today, people may come back or see the webinar on demand when they want. And apart from that, just our deep thanks for your participation and for the participation of everybody that was today during this live webcast. Okay, bye now.
Thanks to
Thank
you
you.
all. Bye.
Bye-bye.
Thanks.
Bye.